So Jennifer, let's talk about infant CPR. First of all, what age group do we consider infants?
So we consider infants anything from newborn, 0 to 1 year of age.
All right, so basically 12 months. And now many times the callers may tell you the child is 12 months, 18 months, 24 months old in the development stage. Again, 0 to 12 months or 0 to 1 year old.
As we move into this protocol, and as Jameson mentioned, this could be one of the most difficult calls of your career. Remember that this could be from a third party. It could be a babysitter that's dealing with an infant that may or may not know this infant's history. One of the first questions we want to ask, once we determine that the child is unconscious and not breathing normally, is there anyone there on the scene that is trained or that knows CPR for an infant? If it's at a daycare, they very well could have someone in-house that knows how to perform infant CPR, which will assist the telecommunicator on this call.
Great point, very good point.
So we're going to ask if anyone there knows CPR. If they do not, we're going to remind them, we're going to help you through this. We're going to tell you how to do it. Listen to me. So the first thing we're going to do that's a little different from our adult and child protocol is we're going to tell the caller to bring the baby to the phone versus taking the phone to them. It's just easier with the mobility of an infant to get the baby closest to the phone.
Right.
We're then going to tell them to lay the baby flat on their back on a table, on the floor if there's not a table available, as long as it's a hard surface. Lay the baby flat on their back. Lift the chin slightly and make sure that the neck remains level. In contrast to an adult and child where we're telling you to tilt the head back, on an infant, because of their airways and the size of their head, we want them to remain in that neutral sniffing position.
Okay.
If this call is related to a possible choking, we're going to look inside the baby's mouth and remove anything that we see that is an obvious obstruction. Again, no blind finger sweeps. We're going to then tell the caller to tightly cover the baby's mouth and nose with their mouth. Again, a little different because of the shapes of their airways and the size of the infant. We're going to be covering the mouth and the nose instead of just the mouth. Immediately, we're starting with 2 quick breaths, and then we're going to have them come back to the phone. Remind them, too, that you might be talking to responders and giving them directions to their address. So remind the caller, if you come back and don't hear me, I'm still on the line. You don't want them to think that you disconnected and then hang up.
And sometimes this would occur because if you've ever been in those really high stress, intense environments, your senses change and the person may come back to the phone and you may be talking to them, but they may be just kind of zoned out or a tunnel vision issue, or maybe they've just given 2 breaths to an infant. They may not hear you at first. So again, remind them, don't hang up, stay on the phone with me, because it could be multiple issues that lead to that miscommunication between you and the caller.
At this point, remind the caller, I'm here, I'm going to tell you what to do next. We're going to ask the caller to put their first and middle fingertips on the center of the chest. Again, in contrast to an adult where we use the heel of our hand. Smaller person,
right.
Smaller need for chest compressions.
Right. And the bone structure is different on infant as well, right? It's not quite the same hard construction that we have in an adult or even in a child.
Right.
And so when you say first and middle finger, and the caller may understand first and middle finger because maybe there's a language barrier or maybe there's some other issue there. Again, we can say pointer finger or whatever it is, but again, it's just two fingers right in the center of the chest.
We're going to then instruct the caller to push down on 1/2 of the depth of the chest. Do it 30 times rapidly and count out loud. 1, 2, 3, 4, 5, all the way to 30. 2 fingers, half depth of the chest, and 30 times.
Now, infant heart rate is completely different than an adult or a child's heart rate, correct? So
yes.
This seems to be really quick, and we're not going quite as deep, but because the infant heart rate's much higher, typically, okay?
Okay, next we're going to tell the caller to lift the chin slightly, making sure again that the neck remains in that neutral position, and then give 2 quick breaths of air. Then we're going to instruct them to go back with their first and middle fingers, 2 fingers, on the center of the chest. Push down 1/2 of the depth of the chest, 30 times rapidly, count out loud. 1, 2, 3, 4, 5, and then follow with 2 breaths. Again, just repeating the cycle.
That's pretty important to understand too, because this cycle is going to happen over and over and over and over again. And each cycle is only going to be 15 to 20 seconds, right? Because we're doing compressions really quickly in that 15-second time frame, and then we're giving 2 quick breaths, and we're right back into the cycle again. So if you're in a comm center that maybe where you're doing what we call a vertical dispatch, where you take the call and you're dispatching resources because of manpower issues or because of operational needs, this is one of those moments where you're going to be really focused on that caller, and if you can, take some of those responsibilities of dispatch and give it to someone else so that they can take care of the dispatch function, you can take care of the caller in this moment. Again, very emotional time frame. I would say that probably of all the calls I have taken in my career, the calls for infant CPR really do hang with you. And I can attest that for a very long response time where I lived and worked, one of the first infant CPR calls that I had taken was about a 16-minute response time. And even though in the back of my head I'm thinking 16 minutes of CPR with an infant, why am I even trying? And that's just in our mindset being realistic. So I'm on the phone with the mother. She's trying to give CPR. I'm giving the instructions over and over and over and over and over again. And we're waiting, it seems like forever for that response to get there. Even law enforcement was trying to get there quicker. And I can remember her passing the child off to the father. He was doing CPR in the background. The mother just completely went silent and still and calm and just, okay, we're waiting. It's almost like she just felt this, I don't know what she felt, but she just changed. The tone changed with a caller in the middle of this, and it was really eerie. And then about 2 or 3 minutes before EMS arrived, the first officer was almost on the scene. He was also an EMT. EMS was just behind him. And you could hear the stress in my voice on the radio. You could hear the stress in the responder's voice. About 2 minutes before they arrived on scene, I remember hearing crying in the background. And, oh, man, just elation, right? And just right now, almost 20 years later, I'm getting goosebumps about it. And I'm talking to the mother. I'm like, okay, I hear crying in the background. Is that the baby crying? Because that tells me immediately that what? Baby's breathing, right? Which means they're breathing normally. They're crying. That's good. And her response was just flat. No, that's my husband. And I lost it. I was a wreck. I was doing my best to try to work that protocol, but I was a wreck at that moment. As a telecommunicator call, I thought, what is the purpose? In those moments, as a TC, we really have to stay focused on our caller and understand that maybe we should emotionally detach from this call for the moment so we can process it, at least until EMS arrives and we can step away from the console. But again, those moments are really important because when you realize them, they're going to hit you like a hammer. And it's going to be very difficult to work through these calls many times. So as emotionally distressed as the callers are, we can feel that as well as telecommunicators. That's why the protocols are so important. We don't need to be able to rely on our memory, no matter how good it may be, to work this process over and over and over again when we're being emotionally impacted as well. Stick to the protocols, know where they're at, work through them. Now your protocols that you use locally may be slightly different because your medical director may want to change these a little bit of the wording based upon your locale. The wording may change slightly, but again, when the medical director signs off on this, stick to your protocols, because no matter what happens, if the call itself and the caller goes really dormant or silent or escalates really quickly, or you have an infant at home and it's affecting you deeply, the protocol is going to help you work through that process. That's why we take our time with this, and that's why TCPR is so important and completely different than taking a CPR course in person. So we talked about earlier with the callers with child and adult, we talked a little bit about vomiting, and we know babies spit up a lot. So if we're in the middle of this process and the baby vomits or spits up at the moment, what do we do differently with an infant than we would do for a child or an adult?
So for an infant, when a caller reports vomiting or secretions of some sort, spit up is the term that you might hear, you're going to instruct the caller to turn the infant's head to the side. Sweep it out with their fingers before they resume ventilations. Again, no blind finger sweeps on an infant because of the size of their airways and the proportion to an object that could be pushed down.
That's right.